Imagine a tiny, hidden tumor, maybe no bigger than a golf ball, but it's capable of unleashing a hormonal storm that throws your entire body into a state of absolute crisis. Today, we're unmasking pheochromocytoma, a really rare condition with some dramatic and honestly pretty mysterious symptoms. All right, so here's our roadmap for this little medical detective story. We're going to start with that crisis it causes, then use a classic memory trick to understand what we're dealing with. From there, we'll follow the clues, find the tumor, and then walk through all the critical steps for treatment and, of course, what life looks like afterward. So, where does this whole journey usually start for a patient? Well, it almost always kicks off with a sudden, really alarming set of symptoms that can seem to pop up out of nowhere. Picture this. You're hit all at once with this classic triad of symptoms. We're talking an intense, pounding headache, a heart that's just racing out of your chest, and a sudden, drenching sweat. You can imagine it's a terrifying experience that, for good reason, sends people scrambling for answers. And the culprit behind these attacks? It's a condition called pheochromocytoma and paraganglioma, or PPGL for short. Now, these are rare tumors, usually found in the adrenal glands, which are these little glands sitting right on top of your kidneys. And the problem is, they go rogue and start overproducing catecholamines. Yup, the exact same fight-or-flight hormones that are responsible for that feeling of sudden panic and alarm. And this totally explains why the symptoms feel like an attack. The tumor isn't just leaking these hormones out steadily. No, instead, it unleashes them in these massive, random bursts. And it's that sudden hormonal flood that triggers that classic trio of headaches, palpitations, and sweating, often in these episodes that just come and go. So to get a better handle on these tricky tumors, clinicians have this really simple but super effective memory aid that kind of breaks down the key characteristics. It's called the rule of tens, and it's just a classic little tool that gives doctors a quick statistical snapshot of the condition. It breaks down its general features in a way that's really easy to remember. So this rule paints a picture in really broad strokes. For example, while most cases just pop up randomly, about 10% are genetic, meaning they're linked to a mutation you can inherit. And while the huge majority of these tumors are benign, 10% are malignant. That means they have the potential to spread to other parts of the body. It's also usually a condition we see in adults, but about 10% of all cases are actually diagnosed in children. And finally, while it's most common to find just one tumor, in 10% of cases they're bilateral, meaning they show up in both adrenal glands. Now, I have to say, while the rule of tens is a fantastic starting point, modern genetic research is showing that these numbers are kind of shifting, especially that genetic link, which we now know is much higher than we originally thought. Okay, so a doctor hears these symptoms and starts thinking, this could be PPGL. What's the very next step to confirm it? This is where the real detective work kicks in. Now, you'd probably think the first move is a CT scan to go look for the tumor, right? But nope, that's not it. The investigation actually starts in the lab, searching for these specific chemical clues these tumors always leave behind. And this is where the experts really weigh in. This quote from the Endocrine Society's clinical guidelines points us directly to the gold standard test. They say you have to measure these compounds called metanephrines, either from blood or from a 24-hour urine collection. So here's why that's so important. Metanephrines are the leftovers, the breakdown products of those fight-or-flight hormones. And because the tumor is making these byproducts continuously, unlike those on and off bursts of the hormones themselves, they're a way more stable and reliable thing to look for. It's like finding the lingering smoke instead of trying to catch a fleeting glimpse of the fire. Right, so once those lab tests come back positive and we have biochemical proof, the mission shifts. Now we have to physically find the tumor inside the body. And now we get to the scans. The guidelines usually point to a CT scan as the first choice, mainly because it gives a super clear, high-resolution picture of the abdomen. But an MRI is definitely the go-to in specific cases, like for kids or pregnant women, where you want to avoid radiation. The choice is always tailored to the specific patient. Finding the tumor is great, and it sets the stage for the ultimate treatment, which is surgery to remove it. But, and this is a huge but, you can't just go in there and take it out. That would be incredibly dangerous. There's a critical preparation phase that absolutely has to come first. And here's why. If a surgeon so much as touches that tumor, it could freak out and dump its entire supply of hormones all at once. That would cause a catastrophic, life-threatening spike in blood pressure right there on the operating table. So to prevent that, patients are medically prepared for about 1 to 2 weeks before surgery, just to block the effects of all those hormones. And there's a very specific game plan. Step 1, start alpha blockers. These relax the blood vessels and get the blood pressure down. Step 2, add a high sodium diet and lots of fluids to get the body's fluid volume back up. Step 3, and this is key, only after the alpha blockers are working, beta blockers might be added to control super fast heart rate. Getting that sequence right is absolutely crucial. Once the patient is all stable, then and only then can surgery safely happen. So after a successful surgery, the tumor is gone, which is fantastic news. But the patient's journey isn't quite over yet. Long-term follow-up is totally essential to make sure everything stays good. What does life look like after this? Well, it's all about making sure that tumor doesn't come back. The guidelines recommend yearly lab tests for life to screen for any recurrence. And this is really important. They also recommend genetic testing for all patients because finding a hereditary link could be a huge deal for family members. Honestly, this whole process is best handled by a specialized team that can put together a personalized, lifelong care plan. And this brings us to a final, really powerful idea. The modern way we manage PPGL, using these specific biochemical clues and genetic insights to create a tailored plan, it's basically a blueprint for the future of medicine. It just shows how we're learning to decode even the rarest diseases, moving away from those one-size-fits-all treatments and into a new era of truly personalized care. So the big question is, how soon can this kind of precision become the standard for everyone?